Good morning. Sunday, a day to unwind and leave stress behind. Good morning, everyone, all respected honoraries and dear colleagues. Myself, Dr. Swati Patil from AOP Yavatmal, is deeply honored to welcome you all on this very refreshing Sunday, brand new Sunday morning, filled with today's PATH session, that is Pediatric Action Plan for Teenagers' Health. Very interesting session today on gender dysphoria by MahaIP in association with Nashik IIP. I want to thank MahaIP President Dr. Ram Gopal Shizara sir, our beloved MahaIP HSG Dr. Amol Pawar sir, Senior Pediatrician respected Dr. Atul Kanikar sir, Nashik AHA President Dr. Sangeeta Lodha Madam, Nashik AHA Secretary Dr. Sulbha Pawar Madam, for their progressive efforts for making this PATH program successful, and it is going on since last 1.5 years. We are having our very eminent speakers today, Dr. Tushar Godbole sir, Dr. Sonia Kanetkar madam, and Dr. Shivaji Mane sir. I am grateful to them for being here today with us. Now I request Dr. Atul Kanikar sir to proceed with opening remarks of today's session. Sir is the vision behind this PATH program for achieving greater heights. Over to you, sir. Dr. Atul Kanikar sir. Sir is not there.
अतुल सर
नहीं, अतुल सर नहीं है सर.
Okay.
So I will request our beloved HSG Dr. Amol Pawar sir to have opening remarks.
Thank you, Dr. Swati, and welcome all the Maharashtra IP members and the members who have joined from all over the country for this innovative pediatrician action plan for teenagers healthcare session. The AHA Nashik and IIP Nashik, they are the combined host for this session through entire year, and since last 16 months, almost 15-16 episodes we have done with the AHA and Central AHA. Dr. Geeta Patil madam also helped us a lot about this. Today's topic, and with this is some different topic about gender transition, gender dysphoria diagnosis management, then what are the surgical interventions in these cases. And today we have got a galaxy of experts. First time all three different types of experts are there in our session. First is Dr. Godbole, Dr. Tushar Godbole from my home branch. He is pediatric endocrinologist. Dr. Sonia Kanetkar madam, welcome ma'am. And she is an adolescent expert and medical legal expert from Bangalore. Then the third one, first time pediatric surgeon is accompanying us on this session. Senior pediatric surgeon Dr. Shivaji Mane from Mumbai sir. So welcome all of you and welcome all the delegates once again. On behalf of entire team, Maharashtra IP President Dr. Ram Gopal Shizara sir, then AHA Nashik team headed by Dr. Atul Kanikar sir, Sangeeta Lodha madam. I welcome once again to all of you and wish all the delegates a happy learning. And also one thing I would like to request, like to tell you that Palghar IIP has graciously allowed us to use their Zoom platform for this session, because another conference is going on with Maharashtra IIP midterm CME along with Nashik at Nashik. So we were stuck in that, our Zoom link was stuck there. So thank you, Dr. Jayasri Deshpande madam from Palghar IIP and whole team Palghar IIP. Thank you, and once again I welcome you all, and over to you Swati for further proceeding. Thank you.
Thank you so much, sir. Gender dysphoria. Why this topic is the need of the hour? Why this causes anxiety, depression, and social isolation in adolescents? And what can be done for that? Definitely, we will get all our these questions answered today. So, firstly, I will invite our very much dynamic and passionate pediatric and adolescent endocrinologist from Dr. Tushar Godbole sir from Nashik. Sir has done many paper presentation. Sir has done many paper presentation for which he has received Best Research Paper Award. He has done many national and international publications. Sir has book chapters in Guy's textbook of pediatrics, IAP textbook of endocrinology, and postgraduate textbook of pediatrics. Over to you, Dr. Tushar Godbole, sir.
Thank you very much, Dr. Swati, for that introduction. And at the onset, let me thank Maha IAP for arranging this innovative academic feast. And today's topic is indeed a very, very different and challenging topic. And at the onset, I would also like to thank my fellow speakers, Dr. Kanditkar Madam and Dr. Shivaji Mane sir, for choosing to speak on this difficult yet very, very interesting topic. I'm sharing my screen. I hope my screen is visible in full screen mode.
Yes, sir. It is
Yeah.
visible.
Okay. So in this next 20 minutes or so, we'll be going through different aspects of gender dysphoria. And as pediatricians, as adolescent experts, what is expected out of us? How do we deal with these cases? How do we diagnose? And when is the right time to start their hormonal therapy? These are the few aspects that I'll be touching upon. Dr. Sonia Kanitkar, madam, who is an adolescent expert and a legal expert, she'll be touching upon various legalities of gender, including at what age it is right to, legally change the gender and what is the, legalities of that. And followed by an interesting topic of DSD, that is the disorder of sexual development, that come to us at birth or during childhood with atypical looking genitalia. So this is one interesting fun fact that Nemo fish, also called as clownfish, have the ability to change their gender throughout their lifetimes. So they are born as neuter genders. As they become big, they become male, and the biggest fish in the herd is the female fish. It procreates, it gives rise to the future offsprings, and it dies. And the largest male in the herd becomes a female and then starts procreating. So this is just a fun fact about how gender can change in the animal kingdom. Human brain typically has two varieties. There is a female brain and there is a male brain. So you have a female brain that has more cortical thickness, more white matter complexity, bigger hippocampus in size, better verbal fluency. And there could be argument about this, but undoubtedly the argument will be won by the females because they have better verbal fluency. And of course, there is a male brain which is 11% bigger in size, has got more surface area, bigger amygdala, and better visuospatial capacity. So these are two, distinct features of male and female brain. But of course, there are so many overlapping areas. And it is often said that brain is in fact a mosaic of different varieties, different characteristics. If the characteristics, there are some common characteristics and there are some distinct characteristics for that particular gender. So what is called normal? So it could be a debatable topic, particularly for gender and gender dysphoria. So I'm quoting Oxford Dictionary, where normal is considered as typical, usual, or ordinary, what you would expect. And the Webster Dictionary says that conforming to a type, standard, the regular pattern characterized by that which is considered usual, typical, or routine. So going by what default setting, we have male and female as the genders. But as all of you are students of um, uh, statistics, we know that there will be standard deviation and there will be atypical gender preferences, roles, and identities. So what are these terminologies? So the designated gender, which is typically designated before or at birth, according to the chromosomes and external criteria, the gender identity is the individual's innate sense of feeling male or female or neither or a combination of both. That's the identity. The expression is a gender is presented to the outside world. So if the female identity is female, the expression is also generally female, where the girl would want to dress up like a girl with putting lipstick and bindi. That is the typical feminine expression of that gender. Gender diversity is variation from the cultural norm in gender identity expression or the gender role behavior. That is, although a girl is assigned as a female gender, she likes to dress up like a boy. But that is just gender diversity. What is gender dysphoria? Gender dysphoria is the distress or discomfort that may occur if gender identity and birth designated sex are not congruent. So the child is labeled as male, has got a chromosomal sex of male, has got external genitalia of male, but he identifies himself as a female. So this is called as gender dysphoria. There is a lot of confusion between various terms. So I've thought that let us segregate these two terms. Sexual orientation is totally different from gender identity. A person could identify himself as a male, that is his gender identity, and his sexual orientation could be heterosexual, like in most of the cases, but he could also be a male and having same-sex attraction, that is being gay, or a female identifying herself as a female but has a preference towards female partner, that is lesbian. So sexual orientation is a different thing and gender dysphoria is a different thing. So in gender dysphoria, the person's self gender identity is different from the what is assigned at birth. It's an umbrella of term that is used to describe individuals whose gender identity is different from their birth designated sex. Atypical sexual behavior is often seen in animal kingdoms. It is seen in apes. It is seen in zoos and animals that are kept in captivity, and where the skewed sex ratio is there. When there is same-sex grouping and dominant male in the herd, some amount of homosexual behavior is seen in animal kingdom, and spontaneous homosexual behaviors are often seen in orangutans, dolphins, and sheep. This is the legal definition of transgender person given by the Transgender Persons Act 2019. I'll not pay much details to this here because we have a dedicated session coming up. So the difference between homosexuality and gender identity disorder, we have just seen that the gender identity is congruent with the assigned gender and the orientation is for the same sex. Please remember that the hormonal levels in homosexuality is normal. There could be environmental factors, there could be prenatal factors that are being studied. And similarly, in gender dysphoria also, the hormone levels are normal, but the identity is discordant with the assigned gender. Of course, there are certain environmental factors and prenatal factors in play that are being studied. What is the prevalence of gender dysphoria in the community? If you go through various consensus data, 2017 Youth Risk Behavior Survey US shows a prevalence of 1.8%. The 2018, which was a modified or a better survey in terms of methodology, says that 9.8% of the US youth identifies themselves as a non-binary. So the numbers are starkly high. We don't know the reasons why. In 2021 UK consensus, there are 0.5% of the UK youth that identify themselves as gender diverse. In India, 2011 census mentioned 0.04% as the prevalence of gender dysphoria, or those who don't identify themselves as males or females. And in India, 2021 census guideline data is yet to be available. What is the etiology of gender dysphoria? It is largely unknown, but the postulated reasons are either endocrine abnormalities, such as a low variety of CAH, congenital adrenal hyperplasia, where there is an antenatal and immediate postnatal virilizing effect of the adrenal androgen, or it could be androgen insensitivity, where there is defect in the androgen receptor. In utero exposure to phthalates and certain plastic materials has been postulated to be the cause of gender dysphoria. There is a high prevalence of gender dysphoria in patients who also have schizophrenia and autism. So there is some anatomical or neurological connection. Although the cause and effect relationship is largely unknown. There are postulated hypotheses of childhood abuse, neglect, and maltreatment during childhood that is associated with the gender dysphoria. And there are genes being implicated in various twin studies where one twin, if one twin is gender diverse or gender dysphoric, the other twin is also likely to be having the same condition, probably due to genetic susceptibility. And there are some CYP17 alleles that are associated with gender dysphoria that are being studied. There are some torch infections and other antenatal infections that are also being studied as a possible cause for gender dysphoria. There's this famous Kinley scale of sexuality where 95% conform to entirely heterosexual and largely heterosexual but incidental homosexuals, and there are 5% which follow the spectrum. Surprisingly, gender dysphoria is not on this spectrum, because the difference between sexuality and gender dysphoria is the self-identity. So this gender dysphoria does not come on this Kinley's scale. There have been fMRI studies done on various persons with gender identity and gender preferences. So in heterosexuals, the volumes of hypothalamus and precentral gyri are said to be higher, and the putamen is said to be higher in volume in persons with homosexual preferences. In gender diverse persons with transgender identities, there are subtle differences in the fMRI. Certain areas lit up differently on those fMRI studies, and many more studies are being published recently. So now we know that transgender brain is differently wired from a cisgender, which is often said as the default brain or normal brain. Overlapping fMRI features are present, but there are distinctive fMRI patterns in frontoparietal and cinguloocular regions in a gender diverse person. And different regions in brain are responsible for gender identity and the sexual orientation. In Indian mythology, you can see that Buddha, the first planet, is often referred as a neuter gender. There are mythological characters which keep switching their gender, and there are transgender references in Indian mythology, like Shikhandi in Mahabharata. There are similar references in the Greek and Roman mythology also, where they have portrayed persons with different gender identity and gender preferences. We have seen the difference between homosexuality and transgender, but just for those of you who have joined late, these are the common features and the differences between the two conditions. What are the diagnostic criteria for gender dysphoria? So the DSM-1 and 2 had no mention about it. The DSM-3 coined the term transsexualism. DSM-4 in 1994 gave away the term gender identity disorder, but then it created a lot of ruckus and stigmatizing of a particular group of individuals. So this term of gender identity disorder that was coined in 1994 got replaced by gender dysphoria in 2013 with the DSM-5 version of the diagnostic criteria. So gender non-conformity is not in itself a mental disorder. So although you will find DSM 4 and 5 criteria to diagnose gender dysphoria in itself is not a psychiatric disease. There are psychiatric diseases such as depression, suicidal attempts associated with gender dysphoria, but gender dysphoria per se is not a mental disorder. How do we diagnose gender dysphoria? So in adolescents and adults, these are the guidelines by DSM-5 criteria, where you have to have incongruence for 6 months with 2 of the following criteria. That is the marked incongruence between one's experienced or expressed gender and the primary or secondary characters. The strong desire to get rid of one's primary or secondary sexual characters because of this incongruence, a strong desire for the primary or the secondary characteristics of the other gender, a strong desire to be other gender and to be treated as other gender, and lastly, a strong conviction that one has atypical feelings and reactions of the other gender. So out of these 6 essential criteria, you have to have 2 in order to qualify as having a person with gender dysphoria if you are an adolescent or an adult. And please remember, these features have to interfere with your social and social well-being, and it should cause significant disturbance in your social life, social as well as occupational and other important areas of functioning. If you're talking about gender dysphoria in pediatric age, not adolescent, the pediatric age, there are certain common things, but one important difference is there is also strong preference for certain toys, games, and activities that are stereotypic for that gender, strong preference for gender roles in make-believe play and fantasy play, and a strong rejection of the typically masculine toys in boys and strong avoidance of the feminine toys in girls. So these are the additional features of pediatric gender dysphoria, but you need to have at least 6 out of these 8 criteria lasting for 6 or more months, then only you can consider a diagnosis of gender dysphoria in pediatric age group. And this condition is associated with clinically significant distress or impairment in the social, the school environment, and the other important areas of functioning. What are the issues associated with gender dysphoria? The important issues are, first is the school dropouts, escape from the home. Many of these children, due to lack of sensitivity or lack of understanding of this disorder, they are often taken to various psychiatrists. The psychiatrist will do their job correctly. They will teach the family that this is a condition and you have to be supportive to their preferences, but somehow if the attention and the sympathy is not being given to the child, they often elope from their houses. Substance abuse, almost 35 to 40% of adolescents with gender dysphoria will have some degree of substance abuse, and suicidal ideation, especially if they do not receive treatment and attention on time, many of them would indeed resort to a suicidal attempt or a successful suicide. Gender dysphoria and disorders of sexual development. We have eminent surgeon coming up in the next talk to speak about the surgeries for disorders of sexual development. But then there is a difference between gender dysphoria and DSD. Most of the DSDs do not have gender dysphoria because you as pediatricians will be picking them up, the children with CAH, the children with androgen insensitivity, the children with 5-alpha reductase. If they are picked up on time and they are treated, they will not develop into gender dysphoria. Most of the individuals with gender dysphoria do not have DSD. So this statement is very important because gender dysphoria, a large majority, or I would say majority of them, have absolutely normal hormonal levels. So individuals with gender dysphoria, the gonads are normal, the hormone levels are normal. Most often the identity that is perceived in the brain is different. So there is some overlap present between the two conditions. For example, CAH, 5-alpha reductase deficiency, androgen insensitivity, particularly the partial variety, and testosterone biosynthetic defects, where if they are not detected on time, or if they are having severe variety, then they can have gender dysphoria associated. Moving ahead, can you force someone to see the colors? If a person cannot see blue color, no matter how wonderful the sky is looking after the rains, it's very much blue, or the forest is green, you can tell the person that I am seeing the blue sky or the green trees. But if the person is not able to perceive, you cannot force the person to perceive those colors. Similarly, you cannot force a person with gender dysphoria to resort to what is considered normal by majority of the people. So you cannot force a person with gender dysphoria to just change the gender as per the societal norms. So one has to be understanding of this fact that you cannot force someone to change their gender. There is something called as gender affirming care, where supporting the individuals with gender dysphoria to live authentically without privileging any outcome other than the primary outcome, that is the emotional well-being. That is the primary purpose for the gender affirming care. With with more awareness and exposure, early presentation is common. So nowadays we are seeing children and early adolescents also with gender dysphoria, and pediatricians have to be aware of this condition. Treating children with gender dysphoria is a big challenge. It's a technical challenge. It's a legal challenge also, and it's a big dilemma. So what are the steps in gender affirmative care? So we have a comprehensive approach with endocrinologists, mental health providers, reproductive care specialists, plastic surgeons, and in the center, we have the pediatrician or the physician who is the primary caretaker of this child or the teenager. One has to be addressing their expectations. I had seen one adolescent couple of months ago who came to me. He's a boy, normal karyotype, normal male genitalia, and he has a delusion that he has menstrual bleeding every month. So we did his ultrasound. We showed it to him that he does not have a uterus, but he had that delusion. So this is the psychological or psychiatric disorders associated with gender dysphoria. So their expectations have to be understood and met with, because they might have unrealistic expectation that a trans woman or a trans female who is a boy and wishes to convert to a girl might want to have menses and might want to have a normal conception. So one has to address their expectations and set realistic goals. We have to explain the risks and benefits of the treatment. Hormonal therapies, surgical therapies have risks. There are medical risks such as venous thrombosis, reduced bone mineral density, and puberty suppression, and loss of fertility. So options for fertility preservation also have to be discussed. And one also has to address to their sexual health, because even before and after surgery, they might be sexually active, and they have to be counseled about the risks associated with STDs and particularly HIV, because the incidence is very high in this population. So this is the care team where you have endocrinologist, psychiatrist, dermatologist to take care of the external appearance, physician, pediatrician, fertility expert, and there is a definite role of surgeon in the last stages of gender transition. Hormone therapy, it is often doubted and there are arguments, but generally it is started. Most of the societies now agree that after 16th birthday, you can start with the hormone therapy, and gender reassignment surgery is not to be done before 18th birthday of the individual. These are the hormonal therapies given for trans females, where the male is being converted to a female, where you reduce the androgen by giving finasteride or aldactone, which is the anti-androgen oral drugs. GnRH analogs are given to suppress the LHFSH, thereby reducing the testicular volume and reducing the testosterone as well as the sperm production. Estrogen replacement is then started with a very small dose of 17 beta estradiol, such as I'll not take any brand names, but there are multiple brands available. But start with a very small dose and gradually increase the dose over next 1.5 to 2 years. That gives the female contour to the body. Very important to avoid smoking and alcohol, because as you start these biological males with estrogen, the risk of thromboembolism actually increases, and smoking and alcohol can potentiate these thromboembolic episodes. We have to monitor estrogen, testosterone, prolactin, and lipid levels initially every 3 monthly, and once the transition is complete, you have to monitor them annually. When the conversion is happening from a biological female to a male, then you initiate with testosterone therapy. Although oral testosterone is available as a capsule, but it is hepatotoxic and you cannot take it for months or years together. And that is the reason we prefer injectable testosterone in serially increasing doses. A GnRH suppression therapy is also given to these females to suppress the estrogen production and for the cessation of their menses. We have to monitor the serum testosterone levels and keeping them in male ranges. Again, the injections have to be started very, very gradually, starting from 50 milligrams monthly, followed by 100 and 250, and ultimately to 3 monthly depot preparations of testosterone 1000 milligram. One has to monitor the hematocrit, the lipids, and take care of the hypertension, because testosterone is associated with these side effects. There was a case in the press, it was widely circulated on the social media, that a trans person, a female that was undergoing conversion, became pregnant. So that was the first trans individual publicly going on the record that was pregnant. So you might have read this news. So one has to be cautious about the contraception and IUD till surgery when you are dealing with a trans male, that is a female becoming a male, because before surgery they still have the chance of pregnancy or the risk of pregnancy. So merely starting testosterone does not protect them against pregnancy. So you have to give them the contraception advice and put an IUD until the mullerectomy or the uterus is removed. Surgeries, breast augmentation, gonadectomy, penectomy, and followed by vaginoplasty and vaginal dilatation using the serial dilatation is what is required for the feminizing surgeries. And metoiodoplasty, where the clitoris is released from the its base to increase its length and girth. Scrotoplasty with testicular implants, and phalloplasty with penile implant, which is not commonly done. These are the surgeries done for when the transition is from female to male. However, these are extremely expensive surgeries. Success is limited, and the expertise required for these surgeries is not commonly found. These are the surgeries for gender dysphoria. Senior pediatric surgeon, Dr. Shivaji Mane sir, will be talking about surgeries that are done for DSDs. So we have a separate session on that. Bruce Jenner was a 3 times Olympic gold medalist. He won 3 men's championships, got married, had 2 kids, and at the age of 40, he discovered that he feels like a female, and he converted to Kathy Jenner. So this is one celebrity example where at the age of 40, a person who identified as male converted to female. So there are so many such examples of successful transition, but then there are so many unsuccessful stories as well. So common questions asked in Indian scenarios is, does being a gender dysphoric person have biological basis? Probably yes. Is being gender diverse a disease? We don't know, because we are yet understanding what is gender dysphoria. Can gender dysphoria be reversed? Can you force a person to go back to his birth gender? Medically, no, it is not advisable. Legally also, no. You will land in trouble if you forcefully try to reverse that gender identity to the biological gender. So you cannot go against the person's will, not as a child, not as an adult also. But of course, can it be treated? yes, with gender affirming care with a team approach, you can treat these individuals with a team approach. Rohtak youth killed his family as they refused money for gender reassignment surgery. These are some of the news clippings that I have put from recent times. Kerala's first transgender RJ assembly poll candidate was found dead under suspicious circumstances. So Indian individuals with transgender or gender dysphoria are facing a lot of discrimination. India court recognizes transgender people as third gender. This is 2014, and Karnataka government reserves 79 posts for transgender persons in armed police. So with this, I'll come to the end of my talk. This is the act that one should be aware of, the Transgender Persons Act 2019. And with this, I come to the end of my presentation. Thank you for a patient listening. And if we have time, we can have a few questions.
Thank you so much, sir, for the wonderful session. Thoroughly explained. You have thoroughly explained between gender dysphoria, gender diversity, and homosexuality very well. Sir, you told about one case that boy was having delusion that he has uterus. So one question was there, sir, that does that boy have schizophrenia? One question was it.
So schizophrenia and gender dysphoria have an association, and not just schizophrenia. Many of the psychiatric disorders are often reported with persons with gender dysphoria. This particular person is under a treatment with a psychiatrist. I'm not recollecting whether it was labeled as schizophrenia or not, but yes, that is absolutely possible.
Thank you so much, sir. Welcome, Dr. Atul Kanikar, sir. Sir has
Yes,
joined
madam.
recently.
Yes, madam, I am here.
Yeah.
I'm just typing one question, but let me ask it directly.
Yes, sir.
First of all, the thing is, it's always good to see some people, and Dr. Tushar Godbole sir is one of them. Okay, and this is, I don't know how many meetings we have had so far. The first Sunday usually. Right now, our Nashikon, the conference is going on. So it's rather tied up, many of us, in the conference itself. But Tushar sir has always taught me something new whenever we have had sessions together or meetings together. And sir yesterday also had shown his another talent in excellent singing. So Tushar Godbole sir is a versatile pediatrician, pediatric endocrinologist in Nasik, and we have labeled him as Gem of Nasik IIP. Tushar sir, thank you very much for the talk. My question to you is, what is the earliest age at which we can detect or suspect gender dysphoria? And the second question would be, when do you refer the case for counseling or psychiatric treatment or any other element like endocrinology reference, surgical reference?
So it is often reported that the traits, the gender specific traits, are seen as early as 3 to 4 years, but the gender identity gets fixed by the 5th birthday. So any person around 6th birthday, if he is showing dysphoria traits, preferences, then he should be picked up and sent for counseling. Definitely in India, and I'm sure sir will be seeing a lot of such cases, that children often have those feelings or that sense, but they never express, and it is often during the puberty that they suddenly come out with their problems. So typically we see them between the age group of 12 to 16, but at the earliest, whatever literature I could search, is between 6 and 10 years is what is reported.
When do you refer them to a super specialist or psychiatrist?
I think 10th birthday is what is ideal, because if we really have to do something and we have to diagnose and think about postponing the puberty for a couple of years, then 10 years is a good time, because by then you can, think of initiating the hormonal therapy, although it's a legal debate whether to start hormonal therapy, not as in the gender reassignment medical therapy, but to block their own puberty until they figure out what is their own gender. So I think 10th birthday is the best time, because by then their hormones have not kicked in.
Okay. Before Preeti madam wishes to ask her next question, I have one more question regarding the counseling of parents and caretakers, or if the child is staying in the hostel or educational institute where the residence is provided. And second question would be, my second question. Okay, you please answer that. I'll think about the other question that I had.
So honestly, it's a team job, of course. The counseling part would be largely done by all of you who are the adolescent experts. My job as an endocrinologist comes when we decide to treat them medically with blocking their hormones. So I think Dr. Kanikar, Dr. Sonia madam, both of you are the experts in counseling. So you can answer better.
You are equally good, sir.
No.
The second question which I wanted to know about is what is the incidence or possibility of this child being sexually abused or actually initiating sexual abuse to maybe weaker ones, junior ones?
Very, very high probability, and I think you are referring to one case that both of us shared. It's very, very common to have childhood experiences as being abused or abusing your siblings. So we have had between you and me, we have cases where we have seen that this is extremely common to have such experiences. I cannot quote the percentages, but it is extremely common. So one has to be taking that history very, very carefully.
Is there any connection as between abuse as a trigger for being dysphoric?
Yes.
Or having a GID?
So childhood abuse, not only sexual abuse, but also physical abuse, maltreatment. If the child has not been treated properly, then also the chances of gender identity disorder or gender dysphoria increase. So there are papers, they have shown that maltreatment, physical abuse, mental abuse, sexual abuse, all are associated with gender dysphoria.
Okay. Over to Preeti madam for her question.
Actually,
Preeti, are
just
you
not
there?
Yeah, I'm there. Atul. Thank you, Tushar. That was an excellent presentation. Just one quick comment saying that initially, probably the child does not need counseling; the parents need more counseling. And the second thing is probably we need to also partner with the school, because the child can face a lot of bullying there. So that also becomes important from a pediatrician's point of view. And as both of you emphasized, comprehensive sexuality education is extremely important from the point of view of a pediatrician. And of course, we have our regular referrals to the mental health professional, the indications that should be on, but many times they're not willing to go to the mental health professionals. So we need to do a lot of counseling in these cases. Just sharing a few thoughts. Thank you so much.
Great. Tushar sir, can we move on to the next speaker?
I think it is about time. Yes. Thank you.
Okay. So over to the whatever MOC.
Yes, sir. Yes, sir. Thank you, sir. Thank you so much, sir. Thank you, Dr. Kanikar, sir, and Dr. Preeti ma'am for her inputs. Then we will move on to our next session. Our next topic is legalities of gender transition in India. So now I will request our very much inspiring Dr. Sonia Kanetkar madam to enlighten us on this topic. Madam is a senior consultant pediatrician from Bangalore. Madam is the secretary of IAP National Medico Legal Group, zonal EP of IAP AHA in 2015, 16 and 19. Proprietor of free YouTube channel, The Teens for Free Education, awarded with FIP award, had received National Award of Community Services in 2019 by Central IIP at Indore, and contributor of chapters in many books, and madam has done many publications in medical science journals. So over to you, Dr. Sonia Kanetkar, madam.
Thank you so much, Swati. I'll just share my screen first. Yeah, is it visible?
Yes, ma'am, visible.
All right, all right. So thank you, Dr. Atul and Dr. Tushar for bringing me to this forum. And I'm really glad that IAP Nasik and AHA Nashik has chosen this very interesting topic. To be very frank, even I was not very knowledgeable about it. I told Tushar that you have given me a very less time to prepare for this, but I'm glad that I could read so much and I could myself, learn so much from this talk. So thank you, Tushar and Dr. Atul once again. So
Yes,
let me
thank you
come
so
to this topic. I think it's a very hidden gem in our society, and as Tushar has already said, it is only 0.04% of our census 2011 in our society. So that itself shows how less number of transgenders we have, and the whole topic has been highly ignored till a certain year, which I am going to enlighten you all today. So Tushar has already done this half of my job of telling about the basics and everything. I will just go on the major points. So what is gender dysphoria? As Tushar has said, it's a mismatch between the birth sex of a person and psychological recognition of self, that is gender, and which leads to the gender expression. But it is not at par with the societal norms. Thus, it gives rise to gender incongruence and also called gender dysphoria. Now, let me tell you in very few words. See, at birth, a child is given a sex. It is named as male or female. This is called designated sex at birth. But what happens with the change in environment, how the child is treated at home, how the family treats, what the child likes, all these factors, they bring up the gender recognition of this child. And again, Tushar has told us that at the age of 5 years, the gender of the child is fixed. So starting from 3 years of age till 5 years of age, this child starts learning whether I am according to the society, a male type of person or a female type of person. So this is a very important thing in gender dysphoria. That child is not able to recognize himself as any one of them. So this term transgender was first coined in 1960s. Anyone whose gender identity does not match the gender they were assigned at birth is called this. There are two types: trans women, that is women who were assigned male at birth, and there is trans men, men who were assigned female sex at birth. And there are non-binary people who may have been assigned male or female at birth. Even we sometimes as pediatricians have faced this situation. We don't know what to write in the case sheet. Am I right? Right. So the word was transgender. Actually, earlier the word was transsexual, but it was replaced by the word transgender, advocated by activists like Virginia Prince. Transgender people can make a number of gender affirming choices. Now, this is very important to understand. For us as doctors, we see only the chromosomal sex and how the child behaves, or the gender what we see. But transgender people can make a number of gender affirming choices. How? This might include the way they want to dress, getting prescribed hormone therapy, that also can be done if they want to become another gender affirming surgeries. And many trans people also change their gender pronouns, okay, to align with their identities. So these are just the ways in which a transgender would like to present himself. For example, I'll give you one of the patients. He wanted to be like it was a male child, male gender at birth, male sex given at birth. and he came to me saying that he wants to be a female and he likes to be a female. He wants to, wear female clothes. But the liking was only till then. I asked that adolescent, do you want to have sex change? Do you want to really become only female? He said, no, I just want to dress like a female. So these are the choices these children or these adolescents can make. It is not essential that they may go for medical therapy or surgical therapy. So we have to be aware as pediatrician about such cases also. Now let me come to a very, very important term, LGBTQIA+. Now, this is a very commonly used term nowadays, even in movies, even in universities, colleges, everybody is using this term. But you'll be surprised to know that common people don't know what these terms stand for, and even some of our doctors also don't know. So I thought that I should just give few seconds to let us learn about this. So it's a subgroup that has always been a part of our society since long. L stands for lesbian, that is homosexual females. Gay stands for the homosexual males. Bisexuals means those who are attracted to both the sexes. Transgender, I have already explained earlier. Q can also refer, Q means queer. Queer means questioning. They still don't know what is their gender or sexual identity, so they are confused. Intersex individuals, I stands for intersex individuals who are born with both male and female chromosomes and or sex characteristics. Intersex individuals are not trans, please remember, but their identities are often, erased and shamed about, much like other members of this community. Asexual sometimes is also called ace, and people don't feel sexual attraction at all, right? There is no sexual attraction at all. Last, there is a plus sign at the end of LGBTQIA plus acronym, which means anyone who is not listed in the acronym but still identifies as part of this community. These can include two-spirit, non-binary, pansexual, demisexual, agender, and a lot more number are there. I can't even write the whole list here. So please, as doctors, pediatricians, adolescent specialists, we must learn about this term. You can take a screenshot of this if you want, but please align yourself with the society. This is a very commonly used term. Now let's see, Dr. Tushar has explained the diagnosis very well. I just want to say that the diagnosis confirmation is a very difficult process in trans. Now, gender confirmation surgeries, of course, Dr. Mane will be dealing with it, and they are procedures. So he'll be dealing in detail. So I'm not going to talk much about it. They're also called gender affirmation procedures, already told by Tushar. Now, I'll just give an example. There's a lot of confusion. What is a trans-masculine transition? That means a female getting converted into male. So what we do, masculinizing genitoplasty, we do mastectomy, we do hysterectomy. Then in a trans-feminine transition, what do we do? Penectomy, orchiectomy, vaginoplasty, breast implants, gluteoplasty, facial feminizing surgery, and many other things to make a male into a female. So this was just an example, just a pictorial representation to make ourselves clear what exactly is trans-masculine transition and a trans-feminine transition. And of course, Dr. Mane will be dealing about it. Now, let me come with all this basic knowledge. Let us come to the legal angle of this community in India, which is very important today, as we all know that any patient sitting in front of you today is a legal bomb. It can explode anytime. So you have to be very clear about your legal angle in everything in medicine. Now, till about 2014, this community, transgender community, was a totally unknown community. Nobody knew about them. Nobody thought about them. And they were like totally in a mess. But the watershed came in 2014. On 15th of April 2014, the Supreme Court of India passed its landmark judgment in National Legal Services Authority versus Union of India, also called NALSA. NALSA is a very important authority for any of such legal issues. So what was recognized? What was the conclusion of this landmark judgment? The third gender was explicitly recognized by our legal court. Of course, society has still not accepted it, I agree, but legally the third gender is recognized, and the right to identify oneself, self-identified gender, was recognized. It's a big step for any of these transgender. Then the next step, in Navteej Singh Johar versus Union of India case, there was a draconian legacy of section 3773 in which consensual sexual relationships were not allowed. But with this court case, the right was given to allow consensual sexual relationships for adults of all sexual orientation was introduced. So that means this is not mainly only for transsexuals, but this is for any homosexual or any other kind of bisexual or anything. They're consensual. Please note, consensual is important. Sexual relationships were recognized. So these are the two important things which came in 2014, and this was immediately after the BJP government came in 2014. Next step came in 2019, right? Now that first big step was the base, the foundation of starting a new era. The next step was 2019. The Indian Parliament enacted the Transgender Persons Protections of Right Act 2019. What does it say? It safeguards the rights of transgenders, particularly for promoting the welfare of individuals who are either born as transgenders or who identify as such. As I gave the example of a male who wanted just to wear clothes of female. So it is for promoting the welfare of both kinds of transgenders. Third, definition of transgender was legalized. That is a very important step for any section of society. Definition is a very important thing, how you are defined legally. So section 2K5 of the Act defines a transgender person as an individual whose gender identity does not align with the gender assigned to them at birth and includes trans men and trans women, people with intersex variations, and individuals with socio-cultural identities such as Kinnar, Hijra, Aravani, Yogda. We have all heard these terms, so now they fall under the ambit of transgender. This is a very, very solid thing that came for this community. Fourth, to attain the legal recognition as a transgender, now, it is a different thing to recognize them, but how can you identify? There has to be an ID card. There has to be a way or certification to say this, yes, this person is not male or female, but it's a third gender. So for that also, this 2019 law, they said that they can apply for the change of their sex or for their new gender to a district magistrate under section 56 of the Act for the issuance of a certificate. So the district magistrate then can further go and certify that yes, either this person has gone into any surgical and became this third gender, or they're already medically done, or no, right now medically was not recognized, only surgical. So section 77 of the Act, that is the fifth part, Act specifically addresses that those who have undergone gender affirming surgeries. Now, I want you to understand here. Legally now, what is recognized as a transgender is the person who has undergone gender affirming surgeries. So here, those people who were just taking medical treatment were not recognized. They were not given certificates for new gender. Understood? That is very important to recognize here. Sixth, the legal position on gender affirming surgeries of minors in India is currently evolving, but what they said in the High Court of different states, see, this is a state subject, okay? This whole thing is a state subject. So what happened in Arun Kumar versus Inspector General of Registration 9, the High Court of Madras noted that the mandate of the Supreme Court was not being followed. It thus directed the government of Tamil Nadu to issue an order in compliance with the Supreme Court's declaration. Consequently, the state government issued this, whatever dated 13/8/2019, one order, which is very important. Now, what did this order say? I will read it now. Gender affirming surgeries on children and infants were banned for all purposes, except if it was life-threatening situation. Okay, this is very important in this order. Second, they were very silent now. So this was about infants. See, there was a particular term written, infants and children, but there was nothing said about adolescents. Yeah, there were nothing said about if adolescents, they can do any surgeries. It was totally doubtful. It was totally confusing. Then 7. So this was the legal position of on gender affirming surgeries of minors, right? So this 6th point is only about the minors. Now, let me come to the 7th point in 2019 order. The right to residence of transgender persons is also upheld by the Act. It prohibits the separation of transgender children from their parents. Now here, let me give you what the picture. Let me give you the real picture, what used to happen with transgender. You all know that whenever there's a child born in the family, if it's a male, it's a female, these hijuras, they come to your house and they will dance and all. And then in a really very hidden way, subtle way, they will come to know it's a male or a female. Then they will just take some money and go. But what used to happen if it was not a male, not a female, and the parents used to say, yeah, it's something we don't, it is all hidden from the main public side. Then this child was taken away from the parents. Yeah, as a youngster, even I didn't realize it. I never knew about it. I think our children also still don't know about it. But now this 2019 law has changed. The right to residence has come to these transgenders. They can stay with their parents. They can have a family. They can have a household where their parents and immediate families reside, and they cannot be excluded from the household. So it's a big change for them, that they are not going to some, a bad place, like where all hijras and all, there's some bad, that's lower community, but they have a chance to stay in normal society. Number 8, Section 7 of the Act states that transgender persons who wish to be legally recognized either as male or female must provide the proof of having undergone gender affirmative surgery. Right? So I have already told that this has been there in the law, that they have to have a surgery to prove that they have changed the gender. Okay. But such a requirement has been said to continue to violate both the constitutional spirit of Nalsa judgment as well as the principle of self-identification and determination laid out in the Transgender Persons Act itself. So this was an obstacle. This was taken as a bad law, that only if surgery is done, then only a transgender can show that I have changed my gender and please give me this right. So next, what happened? In year 2020, again, some amendments were made to the rules. And again, this was a good happening. So let me tell you more about it. So government proceeded to introduce this draft, Transgender Persons Protection of Right draft, in April 2020. This is nothing but an amendment, a modification to all that which was written in 2019. Now, what happened in this? Please listen very carefully. This is a very important, again, change of foundation and a better foundation for transgenders. Number 1, transgender persons need not submit proof of surgery under Section 7 of the Act. Even medical intervention may be interpreted broadly. So that obstacle of surgery, because surgeries are very expensive and not everybody can pay for it and get their gender changed. So even medical intervention, as Tushar has already told, that taking hormones, taking other counseling, or any other interventions, medical interventions, may be interpreted and they can get a certificate. I think this is a very big step for any transgender. If we put ourselves in those shoes, I think it's a reason to joy. The act, second number, the act suggests more long-term measures. Now the government has gone forward to make the life better for transgenders. That is also there, of course. Now they have done it over 2014, 2019, and now better in 2020. The act now is thinking in the forward sense, in the future, which is a very good thought process. It says the reviewing of medical curricula and research should be there to enable doctors to address specific health concerns of transgender persons. So that means we as doctors should be more aware, should be more trained to treat the transgenders. Then second, affirmative obligations on government to facilitate access to transgender persons in hospitals and other healthcare. So now government has put some burden on themselves also, that they also need to look into treating the transgenders. As we all know that because of the stigma, transgenders are not treated well, and it is a sad situation. We don't have any proper place for them to be treated. Even toilets are not there. So all these things now our government wants to do it for them, which is a very positive step. Number three, to provide for the coverage of medical expenses by a comprehensive insurance scheme for the gender affirmative procedures, including hormonal therapy, laser therapy, and any other health issues of transgender persons. Again, this is a big step. Till now, most of the transgenders, since they were not earning, they were not having much money, they could not go for surgeries. Now, if insurance covers them, it will be a very good step for them to identify themselves. Fourth, the welfare measures under the rules also require the establishment of separate wards in hospitals and washrooms. We people don't really give so much importance. Toilets are automatically there for male, for female, so we don't think about it. But imagine, as a transgender, you are not allowed in the male side, you're not allowed in the female side. Where will you go? Is it not sad? I think we need to really, really empathize with them. Empathize, put yourself in the shoes and see you have no place to go, but open urinal. So now this has made life easier for them. The general life is easier for them. Then comes fifth one. The act stipulates that whoever harms or injures or endangers the life or safety or health or well-being of these people, he shall be liable to be punished with imprisonment for a term which shall not be less than 6 months, or which may extend to 2 years also. So it's like POXO Act. I'm really happy. It's like POXO Act. Till now, POXO was, just lying here and there, and there were no actions taken, report, nothing was happening. Now here again, because transgenders, they have been treated badly by everyone. Everybody shuns them, and people really bully them. People really insult them. I mean, they have no self-respect. So now, because law is in their favor, and if they have anybody who is treating them badly, they can complain, and law will help them get their identity, get their self-dignity, get their respect. So this is very important once again in this draft. Now, number three. So these were the points in under one of the laws. The third law was the receipt of a certificate of recognition is therefore a legally mandated requirement for transgender persons to be able to access healthcare services. Right? So they just need to have a certificate of recognition by the doctor or the district magistrate, who will give, a doctor will give the gender recognition, and district magistrate gives a certificate, right? So then they can avail all the health benefits. The act has put definition of family for as those related to transgender persons by blood, by kinship, adoption, marriages. So earlier transgenders had no relatives. They were not even staying at home. They had just other transgenders near them, you know, and so there was nothing for them to do. But now they have a family, which is by blood their family. There is a kinship, means friends, or maybe relatives, or if they are adopted by somebody, they have a family, and if they marry somebody. Now, already I have said that, of course, marriages are still not recognized here in India, but soon I hope it happens. So this was just like, having a family of your own, right? Especially now they can give. Earlier, imagine a situation where a transgender is in an emergency. He is not capable of giving a consent. He's unconscious. Now, whom to ask? As doctors, we will face a lot of dilemma. Where should I ask? Who will give consent for this transgender? Right? It was a very sad situation. But now, anybody of these can give their consent on behalf of them, especially in situations involving a medical emergency. Now, number 5, although Section 15 of the Act obligates the government to provide comprehensive insurance coverage of medical expenses, most of the country is yet to offer free or even subsidized medical care for transgender persons. So this is just a point which will take time. It will happen. Now, only some states, but I must give credit to some states who have actually done good work. Some states like Tamil Nadu, they provide free gender affirmative procedures, which is great. While such states like Kerala have formulated a policy on the subject, but have no government-run hospitals that actually provide gender affirmation surgeries. So Kerala is a step behind. They have formed the policies, but yet to implement it. But Tamil Nadu is the fastest. It is giving free gender affirmative procedures, which is a very important thing for any transgender. Now let's come to November 2020. We have been till April 2020. Now in November 2020, more changes have happened, especially in the healthcare of the transgenders. There is something called Indian Standard of Care for these transgenders. The management of the health of transgenders and gender variant persons is guided by version 1 of Indian Standards of Care called ISOC 1 for person with gender incongruence and people with differences in sexual development and orientation. Okay, so it's not only for transgenders, it's for homos also, for other sexual orientations also. And it was released in November 2020 by Wisdom Publishers Daily. I will just tell in detail, little bit in details about this. It was guided, this ISOC 1 was guided by WPATH, the World Professional Association for Transgender Health. I was so
Excuse
happy
me,
to
ma'am.
read this. Yes, please.
Yeah, we are running short of
Okay,
time
okay,
now.
yeah. I'm
So
just finishing. Yeah, this is my last, second last, I think, slide. I'll just finish fast. Okay. Yeah. So the World Professional Association for Transgender Health is an international multidisciplinary professional association whose mission is to promote evidence-based care, education, research, public policy, and respect in transgender health. So imagine the whole world is getting aligned to the needs of transgenders, which are only maybe 0.04 to 1.8% in the world. But it's a moment of happiness. Now, there are various obstacles. I'll just name them because there is no time. So the obstacles are that the guidelines are in place, but the legitimacy of the same, therefore, can be ensured only if ICMR, Indian Council of Medical Research, gives its consent. Then these things will be actually legalized. Second, it is still a subject of complex bureaucratic web. Means these transgenders, they feel there are too many documentations, too many things to be done to get legalized. So that is a little bit of a bureaucratic web has to be removed. So these are the obstacles. Then there is things like for medical intervention, they have to get those certificate of identity, an identity card, all those things. Then third is that even though the Transgender Persons Act and rules replace all prior procedures, but the change in their gender. So the people who have changed their gender prior to December 5th, 2019 are not required to make an application under the new laws, which is actually not a good thing. So it has to be changed. Now, fourth is there is currently also an impending constitutional change challenge to Section 7 of the Act, which I have told earlier. So what is the conclusion? There have been a lot of very good steps starting from 2014 until 2020 November, right? The only thing I want to tell here is the age of eligibility for the affirmative surgeries is still 18 years. You cannot do anything before 18 years of age, as Tushar was asking, and he has told 18 years is the age after which you can do the gender confirmation surgeries, right? Second, it is still a state subject in India, while it's a nationwide problem. So we must give it more importance. So lastly, on a closer examination of the judgment and the legislation, documentation and bureaucracy are the main obstacles leading to discrimination and stigma. A legal framework by Indian government taking along the stakeholder, activists and individuals is the need of the hour in India. Now, there were some examples which I think because of the botched surgery, cosmetic surgery, one lady died, Ananya Kumari Alex 28. She was a transgender. She died. So there are a lot of medical negligence cases because there are no, fixed rules in India still. And even if there are laws, they are not implemented, they are not properly taken care of, they are not taking it seriously. So things are still under the under the carpet. It has to come into the eyes of the society, and as pediatricians I think we can contribute a lot. So thank you for listening patiently to me. Thanks a lot. And now I can answer the question if there is time, otherwise it's okay.
Yeah, thank you so much, madam, for the wonderful session. Ma'am, we have one question here. We can take one question. That ma'am is asking that whether we should mention on school certificate male or female.
So nowadays there is a trend even in government certificates. It is said birth assigned sex. It is written birth assigned sex. So whatever has been assigned at birth can be written there. Because there will be confusion at the age of 5. There will be confusion in puberty. There can be confusion after 18. And as Tushar has given example, there can be confusion at 40. Right? So it's better to write birth assigned sex. That's all.
Yeah. Thank you so much, ma'am.
Thank you.
Yeah. So now we will move on to our last session by Dr. Shivaji Mane sir. About medical management, Dr. Tushar Godbole sir has told us that we can't do surgeries for gender dysphoria in before 18 years of age. And gender dysphoria incidence is higher in individual with DSDs, that is disorders of sexual differentiation, than in general population. So DSDs are a broad spectrum of conditions that result in babies' genitalia not well formed or having characteristics of both sexes. So to throw the light on this topic, surgical management of DSDs, we are having our respected Dr. Shivaji Mane sir. Sir is the Honorary Associate Professor in Pediatric Surgery in Grant Medical College, NJJ. Sir has many publications, near about 20 publications in international index journals. Sir has received MSR Oration, Spokane Oration Awards. So over to you, Dr. Shivaji Mane sir.
Good morning, everyone. I don't know whether my screen is seen.
No, sir.
No, not
Not
yet,
yet?
sir.
Not
No,
yet.
sir.
Is this in now?
No, sir.
Not yet?
No, sir.
Start
Yes or no?
screen sharing, sir.
So I started with the screen sharing. I don't know what. I'll
So
just
after
go it
start,
back.
after clicking on the share screen button,
Yeah.
you'll get the
I'll do it.
windows.
I'll do it. I'll
Yeah.
do it again.
Yeah. Please select your PPT.
Now share screen, then
You will-
desktop, then share, system preference.
Share screen button is not clicked, sir.
I'll
From your side.
click it. I'll just
Please, sir.
Is it seen or no, madam?
Sir, not yet seen.
Hello? Not
No,
yet?
Not yet.
I'll just, sorry, I'll just leave it again and come back. Just
Okay.
give me a minute.
Okay, sir.
Please, sir.
Dr. Sonia, madam, there is one question for you in the chat box.
Yeah, we can take that question.
So
Yeah,
Sonia,
yeah, please tell me.
so somebody has asked a very pertinent question, and particularly it holds true for your state and the state adjacent to you, because there are, one question was, what if the gender was labeled as transgender at birth and later on turned out to be CAH? What to do then? How do we change the gender at school admission?
No, actually, right now there is no legal law which, at birth we cannot label a child as transgender actually.
Actually, ma'am, in certain states, including Maharashtra, there is an option of not transgender, but I mean,
Other gender,
male,
yes.
female, and other gender.
Yes.
So we have had issues.
Yes, that's exactly.
Yeah.
Yeah. So Tushar, the point is that there are 3 genders now. At birth, if we want to label as pediatrician, it is male, female, and other gender. Okay. Suppose nobody can label as transgender. Nobody can label a child at birth as transgender. That is long gone. I mean, it's not legally recognized. The only thing now legally recognized is male, female, and other gender, right?
Right.
So now if we say other gender, birth assigned other gender, obviously then later, whatever is the situation, as per that, other gender will be put in the certificate. So this has to be very clear in the minds of pediatricians here who are neonatologists or who are pediatricians going for deliveries. Suppose you are not clear about the male and female of a child, newborn, please don't write transgender. You can write other gender. Save yourself the legalities. Please spread the word. I've already told just now in this thing, what are the laws, right? So that will save you a lot of trouble later also. Whoever has asked this question, that will save a lot of trouble later. Yeah.
And madam, we have heard that gender reassignment surgeries are banned in Tamil Nadu, but that is adversely affecting the correct surgeries for CAH. So people from Tamil Nadu, especially the northern parts, they are traveling to Karnataka, getting their CAH surgeries done in Karnataka, and again traveling back to Tamil Nadu. So that's the legal loophole currently, because the laws are state specific currently. So children from northern parts of Tamil Nadu are coming to Karnataka for DSD surgeries.
Yes.
Yeah.
I think such kinds of immigrations are always there. Medical tourism is, prospering because of that. So, and even, since we are not having those marriage allowed in India, so people are going abroad and marrying and coming back. So there are a lot of such things happening till the laws are really clear, right? So
Sorry,
But yes, Tamil Nadu, as I said in my
Is-
first
is my
this
screen is
thing,
seen or not yet?
that Tamil Nadu is the first state. Yes, sir. Now it is seen. Yes, sir.
Okay, thank you. Sorry for delay.
Yeah.
Because
So
of
I hope
technical
Tushar.
edge.
Yes, yes,
Yeah.
ma'am. Thank you.
I
Thank you,
should
ma'am.
make it very
Okay.
clear to begin with.
Yeah, Tushar, it's okay.
I must thanks to Dr. Tushar for inviting me for this meeting. And I was very clear to begin with when I didn't realize till yesterday that I'm going to speak on the surgeries of the transgenders. And then I told Dr. Tushar very clearly that I don't deal with any transgender surgeries. I definitely do a lot of surgeries for a DSD, that is a disorder of sexual differentiation. So I'll restrict myself to the patients of the DSDs. And
Yes.
I really don't have much experience with surgery for transgender. And you all are aware that transgenders are totally different people than the DSD. So I will restrict myself to the DSD surgeries.
Yes, sir.
And this is the same talk which I gave in 2022 in our National Endocrine Society of India at Jaipur. So as we know, commonly done corrective surgeries and DSDs, one is the feminizing genderplasty for somebody who has, there is a masculinization of external genitalia and their karyotyping is like XX. So they need a feminizing genderplasty. And patients with a, say, 46XY karyotyping, but having a, say, external genital are not adequately well developed, they require a masculinizing genderplasty. Some patients require just a vaginoplasty, gonadectomies, surgery for gynecomastia and testicular prosthesis. So begin with the what is the ideal age for the surgeries? As we all know, the surgery for any sex change, or rather for especially for transgender, is obviously above after puberty. This is a very controversial point, especially for DSD cases. Though we know the post-puberty patients will be ideal to give consent for this, maybe taking part in a decision making for the change of surgery for extra genitalia. But we know in our Indian society and so background, our culture is different. These patients who don't have the proper external genitalia, they're not easily accepted, not by our society, and even in the not even the families and the patients will be accepted in our society so well. As far the surgical view is concerned, what is the ideal age to do these surgeries? Today, after doing so many cases of the DSDs, I'm quite convinced if you operate them at early age, it's easy to do surgery because the depth of the tissue is less, becomes easy. Whereas whenever I done a child above age of 16 or 18 years of age, there's a lot of bleeding. There's a lot of bleeding comes for during the vaginoplasties, especially for if you have to excise the vaginal pouch for some of the DSD cases. So a lot of depth is involved, bleeding is involved. So if you do it early, technically it's much easier to do it and equally good results. So feminizing genitoplasty indications, as I said, common is as congenital adrenal hyperplasia, ovotesticular DSDs, MGD, that is also known as a partial gonadal degenesis, and very rarely some of the cases of the partial androgen insensation syndrome, preferably they are rare as a boy, but very rarely I had two patients where even after age of 15, they wanted to be as a girl only. So we had done a feminizing genitoplasty. File pharyngitis patients, again, though they are XY patients, but if the external genital phallus is too small and doesn't respond to the hormone therapy, then the ideal case is to subject them for a feminizing genitoplasty. But the commonest surgery that we do is for the CH patients, ovotesticular DSD patients, and partial gonadal degenesis. There involves three important steps. One is a clitoroplasty, labioplasty, and vaginoplasty. When you say the clitoroplasty was first introduced somewhere way back in 1961, a person called Schmidt, where, as you can see the picture, initially what people used to do, I also done a few cases like this. We dissect the neurovascular bundle. As you can see here, this is a neurovascular bundle on the dorsal side. This is the corporal body, and this is urethral plate. So we excise the whole of the corporal body from the where it bifurcates till the glans level. But we have seen the long-term results of these cases where surgery was not good, because these are the cases where the neurovascular bundle is damaged. They often lose the sensation of the glans. Sometimes neurovascular bundle is damaged. They can even lose the clitoris. So this is not a preferred technique nowadays. What you do for this type of cases is what is subsequently described somewhere in 1983 by Kogan, what you call a subclinical excision of the erectile tissue. That means we don't excise the whole corporal body. We excise only the tissue which is responsible for the erection, that erectile tissue within the tunica albuginea. So what we do for this is again avoid handling the neurovascular bundle as you saw in the first slide. These are the nerves described by somewhere in Baskin 1999. And these are very clearly mentioned that the nerves goes from dorsally, dorsolaterally as the second picture. So don't make any incision or the dissection on this area because you can lose by dissection. And I've seen a number of patients when you do a later age group hypospadias, when you do a similar dissection of neurovascular bundle, and they do complain the loss of sensation of the glands. So thereby we realize it's better to do a don't touch the neurovascular bundle, take incision on the ventral side as you can see here, and then excise this inside erectile tissue. I'll show some of the very interesting photographs. The important point here remains is that there is a lot of bleeding when you go for the excision of the erectile tissue. So what I need to go do is you have to go to the bifurcation of both the corporal body at the pubic symphysis level, put the tourniquet, that's a rubber band all around it, and then tighten it. And then only you can go for the excision of the erectile tissue. And you can see here, this is the incision of the ventral side just lateral to the urethral plate. Open the tunica albuginea, and this is the erectile tissue as you can see very clearly. Excise it completely from the tourniquet onwards distally till you go within the glans. And this is transfixed with a vacuole suture proximally so that it should not bleed subsequently. And as you can see here, sometimes people do a reduction clitoroplasty because clitoris, some of these patients may be too large to give a good cosmetic appearance. But we avoid doing any external surgeries on the glans, clitoris, because that mutilates, that reduces the sensation of the glans. So what we try to do is try to excise the say erectile tissue within the glans, as you can see in a small video like this. And by excision of this erectile tissue which goes within the glans, it debulks the glans tissue. So we don't have to do any surgery from outside on the glans so as to avoid the mutilation. And this is the erectile tissue that you can see. There is a transfix somewhere proximally. Similarly, opposite side. So what you see here, this is the incision taken on a tunica albuginea, and this is the erectile tissue transfixed proximally. Distally go within the glans so that reduce the gland size, but don't take any cut on the glans tissue. Now, vaginoplasty for the patients of the CH, large number of patients, it is a low confluence. What do you mean by low confluence? You get a urogenital sinus, that means the urethra and the vagina opens in a single channel, that is called urogenital sinus. But in large number of cases of this congenital adrenal hyperplasia, it is a low confluence. So what they need sometimes just a cut block vaginoplasty. As you can see here, the vagina opening is seen clearly, urethra is seen clearly. But this is we need to do is take a small cut to make the vagina very obvious in the perineum. Maybe in small number of cases, we need to do minimal mobilization of the urogenital sinus so as to reach the vagina into the perineum. As you can see here, what you see here, this is the mobilized urogenital sinus, this is urethra, and this is the posterior of the vagina. And we to make the urethra vagina opening very wide, we dissected the skin flap that is described technically as a Fortuner's skin flap, and open the cut to posterior of the vagina midline, and put the skin flap within this posterior of the vagina so as to make it wide opening, and so that this doesn't get narrowed. You can see here, this is the skin flap going within the vagina. This is the vagina and this is urethra. And then, and very small number, I had done only 2 cases of the CH where we need to mobilize the whole of the vagina down, where it is placed very high level, somewhere near the in adults, we can say in a male where the prostate is there. If the vagina opens at that level, probably then it's taken as a high confluence. In those cases, we need to mobilize it completely from the that side, or you may have to replace it by another additional intestinal vaginal segment and join to this vagina. So these cases, we have to mobilize this vagina completely from the posterior wall of the urethra and the bladder, taking care that you don't damage the blood nose of the bladder. So this is a total vaginal mobilization described in technically by Hendren way back in 1960 for other conditions. And we apply the same principle here to mobilize the vagina down to the perineum. After dissecting the urethra separately, you can get the vagina down to the perineum. And this is what we see in most of the cases, almost near normal looking the perineum. This is the clitoris. This is the vaginal opening. You can see very clearly. This is labioplasty, where in fact we use the same prepucial skin for making the small labia minora. And this is another girl who had, in fact, you can see the almost near normal looking clitoris and the vagina and urethra. And some of these patients do require early part dilatation till you get a good mucosal skin lining, say anastomosis get developed. Because sometimes if in early cases, if you don't dilate them in the early part of the things, it can get stenosis and may require dilation. This is the one child who requires dilation, and family accepts it easily. This is quite a big girl. In fact, this is almost 12-year-old girl, and the parents are doing the vaginal dilation at home, and this is quite easily accepted by the parents in the early part. And once you see follow-up after a month, the mucosa is well connected to the skin, then we need not do dilation regularly. So muscular genitoplasty for our cases, as I said, commonly cases of the 46XY DSD, common conditions like a 5-reductase deficiency and or partial androgen insensitivity syndrome. A very small number of cases of partial gonadodegenesis, that is MGD, misgonadodegenesis, and otoscleral DSDs. And very rarely, few patients, where 46XXCH patients, even after post-puberty, after age of around 20, even though they were 46XX, but they were rare as a boy, they wanted to be boy. After psychiatric evaluations, really we have converted, I mean, these cases were converted to the boy. So muscular genitoplasty involves, most important thing is most of these patients, when they got a vaginal pouch, as you can see here clearly, the cases of 5-reductase deficiency, where you can see the vaginal pouch, this is urethra, a small phallus, or rather there is a severe chordae, and then we need to excise this vaginal pouch. You can see here also the urethral opening, vaginal pouch. Sometimes we need to do scope, subject this patient for an endoscopy or the genitoscopy just before surgery to identify. Sometimes the vaginal pouch may be little lying very high in position. And this another child where you can see the vaginal pouch is so long. And obviously he wanted to be a boy. This is a classical case of partial androgen 5-reductase deficiency. He wanted to be a boy at the post-puberty because till that he was reared as a girl because the phallus was looking very small. And typically these are the patients when you don't rear as a boy, post-puberty, there's a severe gender dysphoria and then needs to be converted as a boy. So in a cases, if you diagnose them early, in early childhood also is a case of 5-reductase deficiency by a lot of hormonal tests, as Dr. Tushar, the endocrinologist, they do all this workup very well. And then they refer to us. Now, all these proven cases of 5-reductase deficiency should be rare as a boy. And this is what we do in these cases. Once you identify the vagina, we identify the vaginal opening here. You need to excise the vaginal pouch because we have seen patients where the vaginal pouch is not being excised. They are prone for infections. There are 2 patients in my series where they got a large stone formation within these. They get repeated urinary tract infections. Sometimes they get a repeated what you call is epidermolysis because of the vaginal pouch. So we need to excise that vaginal pouch. We have to take care that sometime, rarely we find that the even vas deferens is connected to the vaginal pouch. You have to take care that you don't damage the vas deferens. As you can see here, this is the vas deferens. And in those cases, you have to protect the vas, take care that you don't damage the vas. So leave some part of the vaginal tissue wall attached to the vas, just quadrate the mucosal side from the inside and leave the other outside wall to the attached to the vas deferens. So this is the muscular genitoplasty. Once you excise the vaginal pouch, you need to correct the chordae first. And sometimes the chordae is so severe, you need to transect this urethral plate to release, to increase the length of the penile shaft. As you can see here, after transecting the urethral plate, the urethra precedes proximally, and there is an increased length of the corporal body of the penis. And this is converted into tube initially, proximally, which gives you another, say, about 2 to 3 centimeter length of the urethra proximal. And distally, we can bridge this gap by the inner proposal pedicle base flap, what you call technically Dierkes tube urethroplasty. Base is nothing but we get a pedicle base inner proposal tube flaps, which are converted into tube and get the urethra from somewhere from the penoscrotal junction to the tip of the glans. And this is done in single stage repair. In very few small number of cases, may not be possible to do a single stage repair. When the dorsal skin is not good enough, then we may have to subject them to the 2-stage repair. But large number, yes, it is possible to do a single stage repair. And this is very classical that what I do is a double face pedicle flap. That means I prefer preserve the outer proposal skin along with the inner proposal skin. And you construct the urethra for inner proposal skin, and the outer proposal skin gives a good ventral cover. This is more a technical part, sorry about this. And now another child, as I said, 46XXCH, we have done a muscular genitoplasty. In fact, this is a boy presented very late. And he wanted to be a boy. After psychiatric evaluation and counseling, This was taken for the musculogenderplasty, where we laparoscopically excise all his mullerian structure, same sitting. We did a musculogenderplasty, and this excised tissue was removed by perineal approach only, and we can see the inner provisional skin flap after correction of the chording. The penis has become straight, and we did the inner provisional skin was put on the ventral side as a free graft. What we call technically is a BRCA stage 1, the first stage of the uretroplasty, where the meatus is pinoscrotal junction, and then distal part we put a graft, and the second stage after 6 months we do a second stage uretroplasty. And you can see here, this is that vaginal pouch which was excised. You close this, and then you do a first stage correction of the chordae, make it straight penis, and then put a graft. And the same patient, after 6 months, this is what you see, the flap is suture on the ventral side. There's no chordae. This is a special technique that I do it. I don't want to go into details of that. I explain to my surgical colleagues how to take care of the glands, keep it wide so that meatus come to the tip of the glands. So there's a technical part, but at the end, what you do is you roll this into a tube. When you convert into a tube from the here, and this is what you see, the nice the straight penis, no chordae, meatus at the tip of the glands. This is the whole repair urethra. And the same patient subsequently will find passing urine from the tip of his penis, the glands in a standing position. They don't need not squat. So there are some conditions in a DSD where there is no external genital ambiguity. As we know, some of these patients classically a complete androgen insensitivity syndrome. They are classically nothing but girls. And when you see them external genitalia, there is no ambiguity. They look like a normal girl, but they can present a different way. We'll explain to that. There are cases like a PMDS, that is nothing but a persistent Mullerian duct syndrome, where the external genitalia, again, there is no ambiguity. Penis is normal, there is no hypospadias, but there is a testes that may not be descended completely. So we'll cover that also. And very lastly, the complete androgen gonadogenesis. They are looks absolutely like a normal female. So when you see a girl with a palpable gonad and inguinal canal, one of the diagnoses we must keep in mind is a complete androgen sensitivity syndrome. But need to confirm that by doing a sonography. Today, with a good sonologist, they'll be able to pick up whether the gonad palpable is a testis or a ovary. As we know it, the pediatricians know it, the neonatologists know it. Quite a good number of patients in a newborn, when they present in the inguinal hernia in a small babies, quite often there is the ovaries as a content, not necessarily always the testis as a content. So one need not jump to diagnose as a case of complete androgen insensitivity syndrome. So confirm with the sonography is the testis, and when take them for the surgery, of course, I'll subject them also when you do a sonography, look for the Mullerian structures within the pelvis. If the Mullerian structures are within the pelvis, it is not the case of then for complete androgen sensitivity syndrome, but it's a normal girl with ovary in that. And confirm with the karyotyping hormonal profile. After I do prefer the karyotyping, only we take explore the inguinal canal for herniatomy. And once you know there is a vast difference in testis, take a biopsy, put it back to the inguinal canal or put it back to the perineal cavity. Don't remove the testes early in the small babies. Keep it there for us till puberty, because it is necessary to development of secondary sexual characteristics in these babies. The secondary sexual characteristics, that is the development of breast, is much better if they live behind the testes, and remove them just at the time of puberty, because they develop a malignancy only after puberty and not before that. So remove the testes, leave them till the either inguinal canal or put it back in the perineal cavity, and remove laparoscopically after puberty. So this is what I already talked about this. And sometimes, if, as I said, it can be not necessarily always a testis, it can be ovary. Rarely we find this particular child, which was nothing swelling, but it's a cystic swelling, transnutrition positive. It was nothing but hydrocellular canal of nerve. So don't jump to diagnosis. Now this is another girl who was a 13-year-old girl presented with a bilateral palpable gonad inguinal canal. The vagina is absent. Obviously, the first thing comes to your mind, are we dealing with a child who is a complete androgen syndrome? She presented basically for the 13 years of age with amenorrhea. But palpable gonads, subsequent investigations showed she was a case of MRKH. Her karyotype was 46XX, and exploration, there was a complete absence of the uterus and vagina, set of normal ovaries and fallopian tube, but there's complete absent of the Mullerian structure otherwise. So we did at the same time sigmoid vaginoplasty for MRKH patients. There is a single stage we use of sigmoid loop, and we can reconstruct the vagina from the sigmoid loop. Other conditions where we use the sigmoid loop for vaginoplasty is the cases of complete androgen insensitivity syndrome. Some of these cases, vagina may not be normal developed. It may be very short. And if you dilate them, in case it doesn't dilate so well by puberty, it's better to subject them for the sigmoidoplasty. Obviously not so early age, but at puberty we can definitely do it. So this is the one of the sigmoidoplasty case of MRK. You can see almost near normal looking perineum. Patients with the persistent Mullin duct syndrome, they present commonly as a bilateral non-palpable testes. The external, you can see here, this is a normal penis, urethra is normal, but they have not been diagnosed and before surgery because we rarely subject them for the karyotyping for this type of cases. When you do a sonography for these cases, you will find the gonads may be placed in the inside the pelvic cavity. One of the good sonologists can pick up the Mullin structures, but when you subject them, in fact, most of the cases are diagnosed on table. Rarely they can present with also with hernia inguinale. When the present with the inguinal hernia, we go for herniatomy and we find that one of the content is a uterus in the inguinal canal. Again, in the case of nothing but a persistent Mullin duct syndrome. And lastly, they can present with a transverse testicular ectopia. I'll explain you as the next case. So this is a case what you see when you put a laparoscope inside these cases of the bilateral non-palpable testes with a normal looking external genital and normal penis. You can see here this normal uterus, though it is hypoplastic, there is a fallopian tube, and there will be also a testis situated at the normal ovarian position. I'm not running this video. I don't know whether you're able to play this video or not. No, but so PMDS, what is the important thing is that when the testes are placed in a ovarian position, it's extremely difficult to get done in a single stage. What you need to do is a two-stage repair. In those cases, what we do is exercise that Mullin structures in the midline, taking care that you don't damage the vas deferens. So divide just in the midline, cauterize the mucosa, and the testicular vessels are ligated first stage, what you call Stephen Fowler's technique. And after 6 months, go inside and then do a second stage orchidopexy. This third entity, what you call transverse testicular ectopia, this particular child present with the right side non-palpable and distant testes. But luckily, sonologists have picked up there is a two testes on the opposite side. As you can see here, there are two testes on the opposite side on the left side. And so when you explore that inguinal canal, what you see here, both the testes on the left side, and there is also hypoplastic, say, uterine structure. This is in the midline, see the uterus, and then there is a fallopian tube on either side. This is the uterus, plastic uterus. There's a fallopian, vas deferens on either side. So what you need to do is in this case, just exercise this plastic uterine tissue, cauterize the mucosa, and just cauterize the mucosa of the and put both the testes from the same side, get into the inguinal canal, and put it across on opposite sides. So both the testes are brought on the same side and put it across on the opposite side, like a bilateral orchidopexy. The third the surgery that we do commonly in the case of DSD is a gonadal malignancy that we are not aware of it. In cases of complete androgen syndrome, seminoma is common between second to third decade of life. So these are the cases where the testes have been there and they are rare, particularly as a girl. Go for a gonadectomy after puberty, after 14 years of age, because the earliest gonadal seminoma is reported in a 14-year-old child. So we leave that till they develop secondary sexual characteristics. And patients of the partial gonadogenesis, that is MGD, gonadoblastos is very common in 15 to 20% of cases. So also they need a removal of the gonads. And this there is DMP, that is also part of the partial gonadogenesis. The gonadoblastoma is very high, almost 46% of cases by 40 years of age. In a case of the overtesticular DSD, gonadal tumor is present in about 10% of cases in a 46XY karyotype and 4% with the patients with the 46XS karyotype. To conclude, the CH patients early feminine genitoplasty is better to avoid a psychological trauma both to the child and to the parents in our society. A CH patient should be rare as a girl, preferably, and subclinical excision of the erectile tissue is a better method of the clitoral recession than excising the whole of the corporal body. And no gender dysphoria is seen in patients with the congenital adrenal hyperplasia patients, complete androgen insensitive patients, and complete gonadogenesis. We know what is gender dysphoria. And pyrephragmatic patients, deficiency patient, preferably should be rare as a boy. If not, there is gender dysphoria is very common up to puberty. Thank you, everyone. I'll be very happy to answer some of the questions. I am sure there may be some people may not be totally aware of the different classification of the DSD, but any questions related to the DSD, I'm happy to answer that.
Thank you so much, sir, for the wonderful session. And we got to know that what all the different surgeries is being done for DSDs. Sir, we are having question here that if chromosome is 45XO and XY mosaic, so do we have to remove internal gonads?
No, it is a question that is commonly what you call is commonly see the cases of partial gonadal dysgenesis. Also very previous what we used to call them the misgonadal dysgenesis. Now the internal gonad, what is your say? They will always have some degree of the Mullerian strictures. So if you're rearing commonly them as a boy, then obviously they need to remove the Mullerian structures from inside, which means we need to remove the uterus, vagina. Either you do the single sitting or maybe two sitting. Also, we need to remove these testes of these patients because these gonads have got a high chance of developing gonadoblastomas post-puberty or second or third decade. And third thing, they need to replace them post-puberty with a hormonal therapy, testosterone for the lifelong, if they rear them as a boy.
Thank you, sir.
There's one more question that
Yeah.
PAIS, for PAIS, what is the surgery, the appropriate age for surgery? That's one
Say it
question.
again, which cases?
Partial
Partial-
androgen insensitivity
Yeah,
syndrome.
yeah, partial androgen insensitivity syndrome. Again, all these cases should be when they diagnose early. Basically, how they present? They present to us with a typically like a severe degree of hypospadias, and one of the gonad is palpable, other gonad is not palpable. And when any child who got a proximal hypospadias with a say severe chordae with any of the non-palpable gonad or the testes, undescended testes, we should first thing suspect is a case of DSD and should be investigated accordingly. Now, once you confirm it's a case of partial androgen insensitivity syndrome, as I said, the gender dysphoria is very common if you rear them as a girl up to puberty. So best thing, whenever that diagnosed as a partial gonadal dysgenesis, even early age group, if possible, give them a cream called dihydrotestosterone, which helps to increase the size of the phallus. And best thing is to always convert them as a boy. So do it early age and to avoid the gender dysphoria subsequently.
Yeah, thank you, sir. So thank you so much, all the honoraries, for a very wonderful and informative session on very rare topic today, that is gender dysphoria. So now we will move on to the end of the session. For that, I would like to invite Dr. Tushar Godbole, sir, to propose vote of thanks.
Thank you so much. And it was indeed a pleasure to listen to both the senior speakers, Dr. Sonia Kanitkar, madam, who dealt in great detail about the legalities of gender, and Dr. Shivaji Mane sir, who taught us various techniques of, the therapies or the surgical treatments that are required for disorders of sexual development. And he correctly told us that DSD surgery early, pick up early treatment is what is required. Earlier, we used to thought as endocrinologists, we used to say that you just do the clitoral reduction first and vaginoplasty can be done later. But sir has taught us that early surgeries are better, and with expertise in surgical fields, now early surgery is the better modality. So thank you, both the speakers, and I would also take the opportunity to thank all the office bearers of Maharashtra IIP, Dr. Chajera sir, Dr. Amol Pawar sir, for attending the session, the office bearers of AHA and Nashik IIP. Also, I'll thank the MOC Dr. Swati Patil madam for this conducting the session. Dr. Shivaji Mane sir, you had some
Just
word
a
of
small comment,
sir.
not comment, rather just I was thanks to Dr. Sonia Kanitkar madam's talk on the legalities. Though I was a little bit aware of the most of the facts, but I really not that I understood completely, but I obviously take a good, say the slide photographs, want to go through that properly. And it's very, indeed, is very, say, talk, which has helped me, I mean, going to help me
Thank you,
to
sir.
understand them better. Thank
Sir,
you.
today when I see one patient, I see them as, future litigants. That is very important. I think each one of us need to learn about that. So actually, sir, I wanted to ask you one question. Sir, Dr. Shivaji, sir. So
Yeah.
when you have these cases, sir, you must have come across transgender also, like how we have discussed today. Of course, you are more into other syndromes and other things. But transgenders, how do you refuse surgeries for them since it is lawfully not allowed? So how do
Yeah.
you manage
As
it?
I said, when I came to know just yesterday, when the topic is more about transgender, and I was very clear in my mind because I don't deal with these transgender patients. And there is something which obviously there's a lot of confusion, at least from as far as the legality is concerned, and the court decisions are concerned. They are confused these cases of the transgender with the DSD, or the DSD with the
Yes,
transgender, totally different entities. And so the
absolutely.
cases of DSD should be treated separately than the transgenders. Transgenders are otherwise normal people who are not
Yes,
happy with their sex of rearing. They want to be different. So the question was about the how do you deal with. I have come across, because I do a lot of DSD cases at different hospitals. So I do get some cases of the transgenders come to me. They especially come, the what I've seen is the patients, the boys wanted to be girls. That is what I commonly that I've seen. I don't seen a single girl who come to me to this wanted to be a boy. So what I've seen is a boy wanted to be girls, and frankly I refuse them. I said, telling them that because most of them are above age of 20, and I told them very clearly, I don't do this surgery. This is a very complicated surgery, and there are specialized people who do this, and I safely refuse them by sending them to the other people who do this regularly. So not that they need a surgical correction, but something which we are not doing it regularly, don't do something because there's a very specialized surgeries. Don't mutilate
yes,
the genitalia. Do it properly if you're able to do it. Otherwise, just don't do it. Because once you damage something there, it is extremely difficult to get a good result subsequently.
absolutely, sir.
So
And
that is
that's
the
the
one has to
reason,
understand.
yeah, and that's the reason, sir, they have banned surgical affirmations before the age of 18 because it's a
Now,
permanent change.
yes. Now
So,
the
so
problem started, I can tell you, is about the some of these special days, even today also, should be managed by the centers, so the people who have got a large number and do it regularly. When I see
yes,
a child operated by someone XYZ coming to me as what photograph that I shown one of the child, that is one of the child, the complete scarred perineum. And this happens only if somebody is not trained properly, doing once a while in his life, probably should avoid this sort of surgery. And these are the patients and the surgeons spoil the name of this, say, faculty
profession.
and the profession. So
Yes,
one has to identify today that some of the centers, people are doing good job in this. Try to
yes,
refer these patients and get it done with the specialized people. Not that is refer, I'm saying that refer to me, but there are many centers who are doing a good work on this. Recognize them. Try to do send all the work to these people where we can get a good results. I can tell you very frankly, I must thanks to the beginning only that I get almost 100% reference from one of the best center in Mumbai is a KM endocrinology department. Though I am attached to JJ Hospital, I did all my basics, MBBS, MS, MSc from KM. But today almost I get 2 or 3 patients weekly coming to JJ for this type of surgeries. So in JJ, I do nothing but a DSD work. Though in my private practice, I do everything. But that is the workload that we get, and that is purely because somebody recognizes that your work, if they do refer this large number, it becomes easy to get expertise into that.
right, right. And there are very few experts now, right now. At least there are very, very few people doing this, sir. That's why. Thank you so much, sir.
Thank you.
So thank
Thank
you
you,
both.
Dr. Tushar.
Thank you both the speakers. Thank you, MOC. And thank you all the office bearers of Maharashtra IIP, Nashik AH and Nashik IIP. So should we, so over to you, Dr. Swati. Do we conclude the session?
Thank you. Thank you.
Yeah. Thank you so much and see you.
Thank you. And whoever
next
gave this idea, Anna, this topic is fantastic. My compliments.
Thank you.
Thank you.
Yeah.
Thank you and have a
Thank you,
great day.
everyone. Bye.
Thank you. Thank you.